Hello guys, so in my previous video I had discussed about the definition, the classification, that is the FICO classification, as well as the risk factors for PAS, that is placenta Acreta spectrum. This is the second part of the video where I shall be discussing about the diagnosis of PAS. So mainly we have the ultrasound parameters, but of course we also need to know the color Doppler findings in the ultrasound. So let's discuss about it. Those who are new to my channel, hi, I'm Dr. Sonali Jagati, Senior Resident Obs and Gynae at SAB Medical College and Hospital, Cuttack, having secured an All India rank of 3546 in NEET PG 2021. So for the ultrasound diagnosis of placenta Acreta spectrum disorders, we have the following findings. First is the loss of clear zone, that is loss of a hypoechoic plane in the myometrium below the placental bed. So below the placental bed there is usually a hypoechoic line which is present, and in the case of PAS that line becomes absent. Also you will see abnormal placental lacuna, which is numerous lacuna often containing turbulent flow, also described as a moth-eaten placenta. Bladder wall interruption, then there is loss of bright bladder wall between the uterine serosa and bladder. This is more often seen in the case of placenta percreta. Myometrial thinning will be seen, that is less than 1 mm, or sometimes it becomes undetectable. Placental bulge, that is abnormal bulge of the uterine serosa into the bladder lumen. Focal exophytic mass, that is the placental tissue seen breakthrough between the uterine serosa into the bladder. So exophytic mass is nothing but the placenta which through and through invades through the uterine serosa into the bladder. So look, if you put a color Doppler, you will see that there will be hypervascularity between the uterus and the bladder, that is between the myometrium and the posterior wall of bladder. You will see a lot of vascularity. Also you will see subplacental hypervascularity, so just below the placental bed there will be increased amount of vascularity which is seen. Bridging vessels, very important. The vessels extending from the placenta across the myometrium beyond the serosa into the bladder or organs. So try to imagine it, that through the placenta across the myometrium into the serosa, then into the bladder, or it may involve in the other adjacent organs. Placental lacuna, that is, we already told about the lacuna in the ultrasound finding. In that you will see a lot of vascularity, so there will be turbulent flow within the placental lacunae on to color Doppler. These are the important signs of on ultrasound and color Doppler which we have to know. Ultrasound is the first line imaging modality, and it's usually combined with the color Doppler. It has excellent sensitivity and specificity in the diagnosis of PAS, provided of course it should be done by a skilled and senior obstetrician or radiologist. The other modality which can be used is the MRI, although in emergency situations and considering the time that it takes to do a MRI, we usually don't do it, but MRI is a gold standard. Let's talk about the management. So in management, most importantly, you should know the guidelines. The ACOG has categorically told that the termination of a patient with PAS should be done between 34 to 35 weeks. Okay, and the RCOG tells that the termination should be done at 35 to 36 plus 6 weeks. Elective scheduled cesarean section should be done. Of course, it should be done after antenatal corticosteroids. It reduces the maternal morbidity associated with vaginal bleeding and emergent delivery. Of course, the patient should be referred to a tertiary center with experience in management of placenta Acreta and a place which has a facility for interventional radiology and ICU care. So in our setup we get a lot of cases of PAS, and ours is a tertiary center. So in any tertiary center which has a interventional radiology backup or a ICU backup, in those places only patients with PAS should be referred. A multidisciplinary team approach should be there, which comprises of the senior obstetrician, neonatologist, and anesthesiologist. Okay. Preoperative ultrasound is advised for placental mapping to determine the upper edge of the placenta before surgery by a trained radiologist along with the operating surgeon, of course. This helps in deciding the uterine incision so that the baby can be delivered without disturbing the placenta. So this is very important to remember, because in a past case we do not want to touch the placenta. Putting an incision over the placenta can lead to torrential bleeding. So mapping of the placenta before doing an incision is extremely helpful. Of course, depending on the patient's vitals and her other comorbidities, the decision regarding the route of anesthesia will be decided by the anesthesiologist. So after preparing the patient, you will do the surgery. Remember that once you open the abdomen, you have to inspect for the placental invasion. Usually, if it is a case of Acreta, it will be invading through the anterior uterine wall into the bladder. Hysterotomy site should be chosen. Hysterotomy is performed away from the placenta. Incision is usually given 2 cm above the upper edge determined on ultrasound to prevent cutting through the placenta. Alternatively, suppose you don't have the ultrasound facility, which is usually not available everywhere, especially in your night emergencies where you don't have that facility for ultrasound and intra ultrasound. So you have to give a classical incision and the placenta is left in situ, and we proceed for the hysterectomy. Uterotonics should be given after delivery of the placenta, after delivery of the baby and placenta in situ. Once decision has been made to proceed with hysterectomy, the hysterotomy incisions should be closed fast and the procedure for hysterectomy should be started. Obviously, the hysterectomy steps will remain the same. Placenta increta and percreta, when invades the wall of uterus and the myometrium, is typically very thin and friable. So the plane between the uterus and the bladder is what makes it very difficult. So to summarize, we should be knowing the 3P, that is the triple P procedure of PAS. This is frequently asked in your Viva questions also, and as residents you have to know it. First is the preoperative placental localization using transabdominal ultrasound to identify the superior border of the placenta. With transverse hysterotomy, when you are planning, you have to give 2 finger breadth above that uppermost placental edge. Second is the pelvic devascularization, that is, we do a stepwise devascularization definitely to reduce the blood loss. The third and the last P of the triple P refers to that in no circumstances are you going to try to separate the placenta. In fact, placental non-separation and myometrial excision should be done, followed by reconstruction of the myometrial defect. So this is in nutshell about the triple P procedure. There is something called as the modified triple P, which you will read in some articles also, and that is exactly the same thing as your triple P, except that the second P, where we spoke about the stepwise devascularization, in that you have to do a bilateral ligation of the internal iliac artery, temporary clamping of the internal iliac artery prior to the myometrial excision, and then bilateral ligation of the uterine artery, and or application of a tourniquet to the lower uterine segment prior to myometrial excision. So these are also some of the proposed methods to reduce the blood loss in case of PAS, especially when you're trying to excise the myometrium underlying the abnormally adherent placental mass. We do not want to separate the placenta per se, because it will lead to torrential bleeding. Also, it will be very close to the bladder, so it can lead to bladder injuries. So this is a nutshell about the diagnosis and management of PAS. The resource I have used is the Ian Donald High Risk Obstetrics and Williams 26th edition Obstetrics. Any doubt, feel free to write in the comment section. I'll be glad to answer. That's all for now. Have a great day ahead.